And very welcome to Pamela Watson here today on the Professional Hypnotherapist Podcast.
Thank you, Aidan. Lovely to be here.
Pamela, maybe just before we get started in terms of the work that you do, maybe just tell us a little bit about yourself.
Okay, so I'm not native from Ireland, as you can tell with my accent. I'm actually from the UK, and I moved to Ireland 6 years ago, just over 6 years ago. We've been traveling over to Ireland for about 20 years. One of my best friends is here, and that was part of the reason that we chose to relocate here as well. So my former life, my former work was in business and finance. So that was my former training. So I suppose you could say I have quite perhaps an analytical brain. It was all based around, as I say, finance, business planning, sales forecasts, developing business development, all of that kind of work went on in my previous role. And from there, I discovered what is called neuro-linguistic programming. So I discovered that in kind of a corporate environment.
How did you find that when you're in the corporate world? Did you find it useful?
It was very interesting. I learned about it with an organization that I was working very closely with. They were sending a lot of their senior management to be trained in NLP techniques. So it wasn't the company that I worked for, but it was one of the partnered organizations that I was working with. And to be honest, Aidan, it frightened me.
Really?
It frightened me. Yeah, because hearing about it in kind of a business context gave me the impression that it could be used in quite a manipulative way. So that really it very much captured my imagination, but also made me a little bit fearful of it, I suppose. And I also at that time I heard a HR consultant talking about using NLP within the workplace, and again in quite a deliberate way. He was involved in making a number of people redundant at the time. So he would be inviting people into his office, having a very difficult conversation with them to let them go, but he was using a particular NLP technique that helped him to deliver very bad news. So it was interesting to hear about it in the workplace, in that kind of an environment.
And when you were using or being trained in NLP, what did your company hope to achieve by using it?
Okay, so at that time, I'd actually stepped away. I'd relocated, and I had the opportunity to look into retraining for myself. So I'd actually left the corporate world. I'd learned about NLP probably in the late 90s, but I started to train in it, I would say it was about 2006 when I started to train in it myself. So it really caught my imagination, and I did a little bit of reading around it. But when I had the opportunity, having moved away from kind of the business world in that sense, having the opportunity to retrain, that's what I chose to retrain in.
And you've obviously, you've learned a lot from using NLP.
Yeah, I put quite a bit into practice. Originally, when I started to train in it, I'll be very honest with you, I did think at the time, I thought I would take it back into the corporate world, and I would use it with organizations. So maybe working freelance, having opportunities like that to work with sales teams to help increase revenue with using NLP techniques, to increase profitability. That was my intent when I very first started to train in NLP. But the training really involved one-to-one work initially in the training, and that's what then took me in a different direction. It became very evident that I didn't particularly want to work within larger organizations with sales teams in that way, but I very much wanted to use NLP, and I wanted to use it in a one-to-one situation, bringing that into individual client work. So that was a development for me with the use of NLP.
Yeah. And as you mentioned briefly earlier with regard to there is an ethical way and an unethical way of using, techniques. And I know that you were in it for the ethical use of NLP. And little did you know back then, that it would have taken you on the road that it has taken you on to where you are today. Because where you are today is a very well qualified and experienced therapist, and you're known as the CBT lady. Is that correct?
It is, yes, yeah.
Um,
So yeah, so you're right. It was kind of a very meandering path, I suppose, that I took initially, NLP. That brought me then into clinical hypnosis. So I trained in clinical hypnotherapy. And from that, I moved into birth education. So with using clinical hypnosis, I trained as a hypnobirthing practitioner. So that all went on relatively quickly. It was kind of quite a move, through these training programs. So it took me in that direction. And from there, it very much for me was about working with the mind. So whereas some practitioners would choose maybe, a touch therapy, a hands-on therapy, for me, it was very much about working with the mind. And naturally with the work that I was getting involved with, it was more probably around mental health. So I trained in things like applied suicide intervention and mental health, first aid, those kind of approaches. Did a little bit of work around end of life, and discovered there that the NLP and particularly hypnosis will be used very much, with people facing perhaps a cancer diagnosis, that kind of situation. So it was very much about mind, about a healthy attitude, a healthy mind, good mental health. That then brought me to CBT. And I suppose my business background, being quite analytical, being somebody that was involved with, say, working with spreadsheets, business processing, business processes, that kind of thing. I suppose my mind suited a CBT approach. So when I started to then focus on CBT, it then became useful to me. I became my first client, I suppose, moving away from the work that I did. That brought a little bit of anxiety for me, stepping into the unknown. I left my previous work, retrained, as I said, but entangled in that was ill health, so for me, I'd become quite unwell. It was a very stressful environment that I'd worked in. So there were health complications that I'd experienced. So yeah, as a person that had faced a number of challenges in this way, I suppose I was beginning to experience anxiety. And when I discovered CBT and found that it was based around helping people with anxiety and low mood, it became a treatment choice for me, I suppose. So the retraining helped me as a person, but very much helped the client work that I was then involved with.
I think what I'm getting from you, Pamela, is amongst all your training and all the experience that you have this natural ability to work with people, and you have an interest in people, obviously.
Very much, yeah. So I suppose that came from perhaps from early life as well, thinking about it. My mum and dad, as I was growing up, they moved home. My dad moved with his work. So, moving into new communities was kind of a challenge, I suppose. But yeah, having to make new friends. My mum and dad at one stage, they were involved in the they were publicans, they had a pub. So again, being involved in that kind of an environment was very much people focused. So I suppose I've got a natural affinity, with people. Yeah.
Obviously, you would have to have, in choosing the work that you're doing, and that's that very evidently comes from you, if I could say that. Now, you're now up until today, you're now doing working with clients, as I mentioned previously, you're known as the CBT lady. And what specific issues are you working? In other words, I suppose what I should ask is, what type of client would come to you to seek your help?
It's interesting. It's interesting that you asked that. It's quite a range, actually. So when I started to train in the UK, going back, over those years, I noticed that there was kind of a reluctance for people to talk about coming into therapy. I didn't train as a psychotherapist then. I would say that I was training more as a coach. So initially, I would have perhaps aligned my business around working as an anxiety coach. So if we think about life, all the challenges that life presents, anxiety, as we know, it comes from within us, but it can be triggered from so many different places. So it could be somebody facing kind of a challenge at work. It could be somebody experiencing a loss, with a loss of employment, a loss of a person, loss of a pet even. So all these experiences that we do have generate anxiety. So people will come in from different directions. It could be very personal. It could be something going on at home for them, within the family, or like I say, professionally, within the workplace. So I began working with adolescents and adults, male and female. And that work, as I say, moved me into kind of birth education. So working with anxious mums to be, or anxious dads to be, that might be, experiencing having a baby for the first time. So that I was drawn to work with people in that way.
Mm-hmm. And in recent times, I know that you've received your master's degree in CBT. Is that correct? Tell us more about that. And indeed, specifically, tell us about the research that you did. And as a result of the research, what you have now available to clients. What's available to clients now?
You're very brave to ask this question. You're very brave to ask this question. So, coming into Ireland, just before I moved to Ireland, I had started training in counselling and psychotherapy. Moving to Ireland, I was continuing in that way, but I actually had the opportunity to study for a master's program here. And I was deliberating, do I do counselling psychotherapy? Do I do CBT? As I say, for me, CBT is a very, very good fit. It fits me personally very well. So I opted to do that route. So that training began just before lockdown, actually. Just before lockdown, I'd stepped into the program. So that was a strange experience, studying through lockdown. The research piece that I chose to do was something that I felt very, very passionately about. So I'd worked with women having children, worked with women around kind of personal health. My personal challenges had brought me to a stage in my life where I needed support, and it wasn't available to me then, but I'm going back over a number of years. So when I stepped into the program, I knew what I wanted my research piece to be. I didn't know how I would formulate it, but I knew exactly what I wanted to look into, and that was menopause. And that was the reason for that is because probably 15 years ago, I'd started entering into an early menopause through some treatment that I'd had, but there wasn't support readily available then, and the conversation certainly wasn't open then. There's been an explosion in about 2019, I think. There's been an explosion around menopause, and we hear this continually now on the television, radio adverts. The radio program that aired last year here in Ireland really amplified the topic of menopause. It's been so taboo. Yeah.
May I ask, what do you attribute the increase if that's the correct expression, in menopause. Now, I know from reading that in terms of cancer and the treatment of cancer can precipitate menopause. Maybe you develop that point for me, please.
It can, yeah, it can. So the reason that we're hearing so much more about it now is because women are finding a voice to talk about this. It's a subject that would have been so secretive, so, as I say, taboo. There's a lot of shame around talking about this stage in a woman's life. So there hasn't been that welcome conversation. There just hasn't been that place to talk openly, feel comfortable talking about it. And I suppose part of the reason for that as well is because the medical model, as we know, it was designed by men for men. Men don't experience menopause, so they wouldn't have the lived experience and understand the all that's involved with that potentially. But equally, women's conditions in this sense are very complex. They're very, it can be a very confusing time, and it would be extremely costly to research this. And I think that's why the research is only now beginning to come through in the way that it is, because more women are involved in research now. It's obviously something that affects 50% of the population. So women are finding this voice, and, we're beginning to talk about it rather than ignore it or continue with this sense of shame around it. So when you link it with cancer, for normal natural menopause, that would occur in the Western world for women at the age of 50-51. Cancer treatment, however, can bring on early menopause or menopausal symptoms for women, in the 30s, who would be typically 2 decades away from experiencing what is a natural phenomenon. So they wouldn't really have prepared for that. So the research piece that I did was based around natural menopause, because my experience wasn't natural in that sense, and I didn't want my experience to colour, the work that I was doing. So I chose to separate that out. But what I wanted to do was to come back and look at the women that experienced something very early that they wouldn't be ready for. Psychologically, they wouldn't be ready for. Environmentally, they wouldn't be ready for. They're not in that place. So that was the interest that I wanted to develop there. So it was based on my personal experience, the lack of support when I was going through my journey, or certainly the early part of my journey, and I wanted to bring something now into the realm that can support women in so many different ways.
And what were your key findings as a result of that research?
It was very interesting, actually. So the key findings were, and we're hearing about this now, so it's not uncommon to hear about this, but the key findings were that women were very much unprepared. So now what we're talking about for the generations coming up would be a kind of a plan to prepare for this. Mm-hmm. So women were very much unprepared. Women were unaware. So not only were they unprepared, they were unaware of what was actually happening to them when it was happening, because the information just wasn't readily available. Conversations weren't taking place. So we kind of stepped into something that was very, for some women, it's not for every woman, but for some women it can be quite traumatic. There's a lot of symptoms that can be attributed to menopause now. There's something, if I was to say to you, Aidan, that there could be something up towards between 50 and 60 different symptoms. That's not an exaggeration. So women were very ill-prepared and kind of uninformed. That was one of the big pieces that came out of it. Another big piece that came out of it were that clinicians equally were ill-informed. So for doctors, if you think about doctors coming through their curriculum, their training, there wouldn't have been a piece on menopause, or it would have been very, very, very scant. There wouldn't have been sufficient training around this particular phenomena. Mm-hmm. So that was becoming very evident. So when women were approaching the doctors, talking about symptoms, looking for support, it wasn't readily available because doctors, again, were ill-equipped, because there wasn't sufficient training around this subject. That was a piece that came out of the research. But yeah, there were many pieces, and all the symptoms, or the number of symptoms that I'm talking about here, a lot of the women in my research piece identified with a number of those different symptoms as well. So it just brought all this information together. It just brought everything together in that sense.
So I'm guessing from what you're telling me that education is really, really needed. Information.
Yeah, very much. Yeah.
Please.
Pardon?
Tell us about that if you can.
Yeah, so last year there was a big piece that came out of I think it's Joe Duffy on the radio, has one of the radio programs, yeah. So he opened up the conversation around menopause, and that just blew up. I think where it would have been maybe an hour's slot on the radio turned into a whole week of conversation around menopause. So it just emphasized the need to have this conversation, to open this conversation. And that was a gateway. Here in Ireland, that was a gateway. And from the back of that, there has been so much more research that has been provided. There's been a piece, the Women's Task Force went through Ireland talking to a number of different women to get their opinion and the lived experience of menopause. So there was a whole piece that was funded by the government to research menopause. And on the back of this now, we're seeing specialist clinics opening through the country. We're seeing different provisions being made allowed for. I think they just reduced VAT on HRT products, for instance. So that there's a lot of work going on that is now coming through that we're seeing, on the back of recent research. And we'll continue to see that as well. Another thing that came from this was the collaboration that's now going to happen between the Irish, now let me get this right, the doctors training, the School of Training for Doctors, sorry, the name escapes me. They are now collaborating with the British Menopause Association to bring it onto the curriculum. So that will be the college that trains doctors.
Maybe it's the Royal College of Surgeons, is it, or something like that?
The Irish College of General Practitioners. That's what it is. The Irish, thank you, Aidan, you got me there. The Irish College of General Practitioners. So they now have a collaboration with the British Menopause Society to bring a specific piece of training into their curriculum. And that's only happened very, very, very recently.
Thank you for that. But you also, as a result of your research, you have come up with an excellent program, and it's called the MENO-CAN program. Is that correct?
Yeah. So the training that I did, the research piece that I did was around natural menopause. But as I said, my experience was a little bit different, and I wanted to then look into that a little bit more. I work with a cancer charity, a cancer support group. I did in the UK. I worked with one for about 4 years before we moved over here. And then I started to get involved with a community cancer support group here as well. And whilst I was doing my training, I was working with women in the cancer support group and with men, but it became very evident that the women who were experiencing symptoms of menopause, perhaps because of surgery or because of medication, were not being supported psychologically. So they would be receiving excellent medical care. We can't fault that. But when they were talking about other things that were going on for them and weren't quite able to join the dots themselves, they were feeling quite dismissed. But I know that the clinicians would have been wanting to help them recover from cancer. So that would be the priority. But equally, when a woman is going through something distressing, as menopause is, in conjunction with cancer, there's something else going on for these women. There's something else going on for them. And as I say, there wasn't the psychological support. It wasn't that evident. So I wanted to create a little piece that I could start working with my ladies with, that would support them in that journey through cancer, through the cancer treatment, but if they've experienced the menopause as well, you know. So that's the MENO-CAN. So MENO-CAN was just a play with words, menopause and cancer. That's what I came up with. But it's a program that's building on resilience, because these women, having faced a cancer diagnosis, faced that head on, stepped into a treatment program, they're really digging into their sense of resilience. And I wanted to build on that sense of resilience with specifically the look at menopause as well.
So can you give us the specifics of the program so that anyone who is watching or listening to us as to what can I expect if I attend this program, you know, or what do I need to actually attend it, or do I need anything, or what type of client would I be?
Yeah. It's actually, you've asked something interesting again there. It's because I was quite, my personality would be such that I would reach out for help, reach out for support. And as I say, when I was going through my particular journey, I constantly looked for support, and, you know, there wasn't really anything around. So that's my personality. However, there would be people that wouldn't want to talk about it necessarily. So it's not going to suit everybody in that sense. So a lady kind of stepping into this program would be, she would be curious, I suppose, and have that open mind, and want to be able to share her experience perhaps with other people as well, because that is part of that recovery journey, isn't it? You know, that we have that conversation. Mm-hmm. So I've been quite surprised. We've run it. We're just in the second program now. We ran it before Christmas. We did get some HSE funding as well to support this. So we were very fortunate. So the first group of women came in, and great. But I've noticed with this, as it's gone on, some women are quite reticent. And it's for some women, it's a very private process as well. So they don't want to share, you know, they perhaps don't want to step into a group for fear of somebody seeing them that they know, because they may not have even shared with even the friends and neighbours that they're going through this cancer journey, you know. So yeah, it wouldn't suit everybody. But for somebody that has that open mind, that's curious, that is digging into that sense of resilience, that wants to build on that sense of wellness, with helpful strategies, that's what the program is about. So we've designed it. I designed it in such a way that it's just a small number of women, only up to 8 women perhaps, that would step into that kind of space. It's not therapy; it's a therapeutic space. You know, so what we're talking about is confidential, and there's no pressure for women to even share their story. They could attend and just be there as an observer and take away something, you know, from what they've learned. So the mini workshops, I've put together a series of mini workshops over 8 weeks, 8 sessions, and each one is a standalone, so they can come in and look at things like symptoms, as I mentioned, you know, because a level of awareness differs, you know, so some women might not, as I say, join the dots. So it's understanding symptoms. We look at symptomology. We look at some of the specific or some of the main symptoms that would cause perhaps most distress, and that would be sleep for some, and it will be anxiety for others, and it might be depression for others, low mood. So they're areas that we look at as well. And as I say, build on this knowledge. It's psychoeducational, so we'll bring in, you know, things into the workshop in that way, but then doing little exercises that would help them understand their resilience, you know, a resilience scale. Not many people have done that before. Do they get a feel for where they are on that resilience scale, you know? So little bits and pieces like that. And another lovely piece that I specifically bring in will be mindfulness. So that will be the guided imagery, and that's the hypnosis part of it as well, I suppose. So that's, you know, that's some of the work that I deliberately bring in, because we're seeing now through research that mindfulness can be used in so many different ways. You know, it has so much value. Yeah, and the training again that I did when I did the CBT more recently, I did a piece on mindfulness in the mindfulness-based cognitive therapy. So that was a piece that I did some training in as well. So I bring it together, and I think I would class myself as a kind of an integrative therapist. You know, CBT is a lovely framework that I use. It gives me a sessional approach if I'm working individually with clients. So that gives me a framework with which to work, and then I would draw in from other areas, you know, that I've trained in a similar way that you would, and a number of so many other practitioners would. Yeah.
What comes to mind now is you may have answered my question already, but if there was one particular question or clarification that ladies going through the menopause would want answered or would seek information on, what would that be?
One question? There are many. there is so many. There are so many.
Common sought after information. Or...
Yeah. It would be, when does it start?
Yeah. Okay.
Yeah. When does it start? That would be a question that some women would ask. How does it present? You know, what are the symptoms? When does it end? That would be a question, you know, that some women would ask. Because, as I say, there is just a lack of awareness, not through any fault of ours necessarily. The information hasn't been readily available as such. Like I say, even speaking with your GP, you know, you can have a very different experience, GP to GP. Even with female GPs that haven't trained, there might be a reticence to go there or talk about it because of their experience, you know. So it's quirky. It's a quirky one.
Now we've mentioned CBT, and you know, maybe we'll just explain what exactly is CBT and why would I need CBT, cognitive behavioral therapy.
Cognitive behavioral therapy, yes. Yeah. So it's very, very helpful. Like I say, the way that it was designed originally, probably, you know, it's one of the newer forms of psychotherapy. So perhaps it came about 60s, 70s, something like that. And it was very much put together to support people with anxiety and with low mood. So that was the whole premise of CBT originally. It was designed to help people with those mood disorders.
Would it have anything to do with our thoughts and our
thinking? It would. So the cognitive is the brain. Yeah. The behavioral aspect is how we interact, how we communicate, you know, how we are in the world, how we are with other people. So it would bring together those pieces. So it very much focuses on this kind of four elements, I would say. It focuses on the thoughts. It focuses on emotions, how we're feeling. It focuses on behavior, but there's also a focus on the physical sensations that we feel as well, not just our emotional state, but the physiology of what it is that we feel. So they're the elements that CBT brings together. And as an intervention, it would look to make change, you know, so if somebody isn't happy with the way they behave, if they've got, say, anger issues and they don't want to have these outbursts, it would look at behaviors. If somebody has got intrusive thoughts that ruminate, those horrible little thoughts that keep going around and around and around, we can work and look at those kind of things. Emotional regulation is a big part of CBT, especially in the way that I work. So if somebody is dysregulated emotionally, we can look at that area as well. But I think in the time that CBT has been here, there's been a lot of change, and this is what drew me back to CBT. And this is what I was saying. I had a bit of a dilemma. Do I continue with the counseling and psychotherapy, or do I go CBT? I trained in CBT originally, I don't know, I think it was about 2010 with an association in Scotland. What's it called? Oh my goodness me. I can't remember now. This is a menopausal thing, by the way, when you have like brain freeze or brain fog.
Was the Institute, was it in Scotland?
Pardon?
Motivational Institute in Scotland.
That was the NLP training. That was the NLP training. So the west of Scotland, the Institute of Counselling, that's where I started to train with CBT. And as I say, that was in about 2010. So it was very much based around negative thought patterns, negative thought processes. Since 2010, there's been so much more development with CBT, and it's classed as more innovative now. So it draws from things like compassion focused therapies, from acceptance and commitment therapy, ACT therapy, mindfulness approaches. It draws from all these other areas now. So CBT has developed in a way that there will be very specific programs that will be designed for use with, say, psychosis or eating disorders or suicidal thoughts, body dysmorphia. There'll be so many specific CBT programs now. And that's happened, more recently. So that's what drew me back to CBT, to go down that route, because it was my first love, I suppose, when I looked into psychotherapy. And because of the change that's happened, I wanted to develop my skills as a practitioner to be that little bit more innovative. And in doing the training, what it's opened up for me is the conversation that I can now have with, say, somebody with a mood disorder such as bipolar or borderline personality disorder or ADHD or Tourette's. I mean, these are people that I would work with that have specific disorders, and CBT lends itself to this. So I'm not saying that somebody should have CBT. What I am saying is that I know that it can be helpful in so many different ways, and that's the reason that I wanted to get involved, because it was the one-to-one care that I wanted to provide. But in doing the further training, it's enabled me to sit with so many different clients in different ways.
So when would CBT be contraindicated? When would you not use it?
If so, now, when I said that it was designed around anxiety and depression, that is true. But I've experienced where, and this has only happened, I'm thinking back now, maybe twice. So I wouldn't use, or it's been a little bit of a struggle with a couple of clients that have been severely depressed. With some clients, it's worked okay with, even though they have been severely depressed. With some clients, it hasn't worked too well with, because CBT is quite directive, as you'll maybe gauge from the way that I speak. It can be quite directive, but it's very goal focused as well. So, we don't necessarily go back over the past with CBT. We don't do the deep psychoanalysis. We can do that, and often we do that. But from the outset, we're starting with, what is the current problem? Where do you want to be? So what is the challenge that you have right now? What is the issue that you're dealing with right now? Where would you like to be? So that's the conversation you have initially. So we create goals. It's like, okay, that's where you want to be. So then we're developing the strategies that might work towards those goals. So for somebody that's very, very depressed, that has no motivation, it might just be a little too difficult for them at that time. They may need a different therapeutic approach. They may need to be able to sit with somebody and to be able to really kind of go back and just talk and release, some of that kind of emotion that perhaps has been stored for so long. So CBT is a little bit different in that sense. So I don't know if that answers your question there.
Thank you for that. I'm thinking also, the chicken or egg situation. And I'll clarify what I mean by that. Which comes first? Is it a thought comes first, or is it a feeling that comes first?
Again, different schools of thought, pardon the pun, but for some, some will get the feeling, definitely, would have the emotion, that can then trigger the thought. The other way around, it can happen as well. Somebody can have a thought and then it can elicit the emotion or the feelings. So, and that's why I say CBT looks at these different areas. So we wouldn't necessarily intervene with thoughts if if that isn't going to be the best place to start. You know, we would look at behavior perhaps, or we'd look at emotional regulation, you know, so it lends itself to come, you know, from a different angle, I suppose.
And I suppose in that regard, it's dynamic, you know, you're going to change. And what I get from you is that it's very much results focused, oriented.
Yeah, it is, because it is very goal focused. It's like, what is your challenge? What is it that you're experiencing? What is it you want to change? What do you want to make happen? You know, what do you want to be different? So it is very much about working towards a goal in that sense.
Mm-hmm. I note that you work with people with personality disorder. Is that how difficult is that, or is it difficult, or is it any different from any other client?
No, it is different. It is different. It can be challenging in a different way. And I can give you an example. I was working with a client that presented with anxiety. So this would be a woman in her 20s, mid-20s. She presented with anxiety, and we started to do work around that. She'd been in the mental health community team. She'd been working with them since adolescence. I think since she was about mid-teens. So she'd been with them a number of years, but wasn't, because, and it's not being critical of that level of care or that way of providing care, but the continuity of care in that situation is quite challenging. You know, a patient, people coming to see me are not patients, but in that setting, obviously the patients. So as a patient, she may go in for an appointment and you know, speak with a consultant, and then on a next visit it will be somebody different, and then on the next visit again somebody different. So she was having to repeat her story, and not feeling really supported. She was very much supported from a medication point of view. You know, they were regularly checking on, you know, what level of medication she was on, how was the dosage, how was that, you know, was that helping, you know, so she was getting very much support in that way. But from a psychological viewpoint, she wasn't really, because of this inconsistency, she wasn't in the best place. So she came for CBT, presented with anxiety. After a number of sessions, now, if somebody's presenting to me with anxiety and I don't feel, you know, from the intake session that we have, if I don't feel there's much underlying that, much else underlying that, if it's generalized anxiety, you know, general anxiety in a sense, I would say, you know, 8 sessions, you would definitely be feeling different. Definitely be feeling different. If you put in the work in, if you put in the effort, like I say, it's motivational, you know, we need to keep it moving. Somebody would be feeling a different change in that time. So the CBT could be classed as a brief therapy. Yeah. However, for somebody with a mood disorder, sessions can go on much longer. So then it isn't a brief therapy in that sense. And we may have to go back and revisit other areas that we wouldn't have expected to. And with this particular client, it became apparent to me, I wouldn't make a diagnosis, I'm not a doctor. But obviously working with the DSM-5, as you know, we're able to look at particular traits and see, you know, if we've got a particular suspicion or if we've got particular thoughts, we'll go and consult, and, you know, we've got the reference material to work with. So I'd got a feeling that there was something else going on, and I asked if she would go back for a reassessment. And this particular woman was then diagnosed with borderline personality disorder. So she'd been diagnosed with anxiety initially, but I felt there was something more going on. I challenged that, and that was difficult in the session because, as we know, giving labels to people as well can create problems. You know, so I didn't want to make the situation worse, obviously, but from a practitioner viewpoint, I needed to know that I was giving her the best care. You know, I had a duty of care to her, and I wanted to make sure that she was on the right medication. So she went back, she did have a further diagnosis assessment, and yeah, personality disorder. So we did a number of sessions way beyond what I initially thought we would. So that was very different. And working with somebody with, say, bipolar,
Yeah.
those kind of mood swings almost. Again, that can be quite challenging, because for those clients, even coming into a session can be challenging, depending on what their mood is, what their state is. And you might find that those clients may cancel last minute because they're not feeling great, they're not in the right place that they can come and attend a therapy session. So there is a challenge, and being a practitioner, you're trying to work consistently, but it may be that it's a little bit of stop-start. Yeah, and neurodiversity as well, and we're seeing all these different conditions coming through, with brain disorders. So again, working with clients with Tourette's or OCD would be highly challenging, and again, that would go on over many more sessions to help them, regulate and live in a world that's really challenging for them.
Great. And what comes across is, your professional attitude, your integrity as a therapist, and your care, above all, your duty of care, a genuine care that you have for your client. Now, out there now, I'm sure anybody watching this, maybe there's somebody watching this who, is struggling. What message would you have for someone who is watching this, or indeed maybe somebody who knows somebody, maybe a loved one is struggling? What would your message be to them in terms of seeking help?
My first comment would be to try. I would like to try and persuade people not to struggle alone, and that's for the person that has the challenge, or for somebody that's caring for somebody with a challenge. Not to just sit with this by yourself, to take a step, to take one small step. I know how difficult it can be for clients to come into the room with us, and I know that can involve a lot of deliberation as well. So there can be a lot of time spent trying to figure out, am I doing the right thing? Will I be seeing the right person? Will I be safe? Can I trust this person? There's so many questions that would be in somebody's mind as they take, make that decision. So my first would be reach out, take the smallest step. Now with the internet, we can do so much research, good and bad. You've got to be very measured as to what you're looking at as well, I suppose. But there are support groups. There's so many support groups. Practitioners working privately as I do, community support. There's so much available to us that can help when we're struggling. So it's take that first step.
That first step. And that's a very poignant, apt time to conclude our discussion here today. Take that first step. So how can we contact you, Pamela Watson?
So you quite rightly said, I am the CBT lady. So that actually came about. It was a friend that suggested that. She said, you're the CBT lady. Why not call yourself the CBT lady? So I ran with it. So I do have a website. So it would be www.thecbtlady.com. I'm on social media platforms as well. I can be found that way. I work with a community therapy centre, so based in Ennis, and that would be the Ennis Therapy Centre. So they have a website as well. My details are there. And the community cancer support group that I work with, which is GORT Cancer Support, Hollyblue House. My details are with them as well.
That's G-O-R-T, isn't it?
Yes, G-O-R-T, GORT.
All right, Pamela Watson, thank you so much.
And thank you, Aidan. It's been a pleasure.